Let's talk about the management of heart failure. As I told you, management includes investigation and treatment. Here, heart failure, we have done almost all physical findings and general physical examination as a part of investigations. No specific investigation apart from 2D echo. We talk about the general measures in the management of heart failure. So what are the general measures? First is patient education. Explain the patient about the nature of the disease, treatment and self-help strategies. Next is diet. Patient should take a good nutritious diet for weight reduction and obesity. Patient should avoid high salt dense food, extra added salts like pickles and etc. Then patient should be explained about the severity of the congestive heart failure. Alcohol should be used in moderation, or elimination of alcohol consumption is the best thing in case of heart failure, because alcohol induced cardiomyopathy is shown to reduce or revert back if patient is in abstinence from alcohol. Next is patient should stop smoking. Regular moderate aerobic exercise should be done with limitation of symptoms, that is at least 20 to 25 minutes per day for 5 days in a week. This is what we mentioned. Next, vaccination against influenza and pneumococcal vaccination is recommended in all the patients who are elderly and present with recurrent heart failure. So in the first pharmacological management of heart failure, we talk about diuretics. You begin your treatment with diuretics. Diuretics in heart failure, what are the important points you need to remember? It improves the congestive symptoms. Whenever you use a diuretic, the left ventricular filling pressure is decreased without any decrease in the cardiac output. This is very, very important to mention. Patient becomes euvolumic state without even decrease in the cardiac output, and there is no reduction in the mortality because of diuretics except for spironolactone. Loop diuretics, what do they cause? They enhance the free water clearance, or the impaired free water clearance is enhanced or corrected by the loop diuretic. It does not slow ventricular remodeling. Remember, diuretics will not cause any change in the ventricular remodeling. Combination of diuretics along with ARNI, the angiotensin receptor neprilysin inhibitor, should be the initial treatment for most of the patients, with immediately followed by addition of beta blocker. Now, how do you manage heart failure with reduced ejection fraction? 2 drugs you have to use. I told you, diuretics along with ARNI, that is valsartan sacubitril combination. So valsartan is a ARB, sacubitril is an NI, neprilysin inhibitor. NI means neprilysin inhibitor, ARB means angiotensin receptor blocker. So along with this diuretic, this is a management of heart failure with reduced ejection fraction. Within 2 to 3 days, the patient develops euvolumic status. Once the patient develops euvolumic status, now you have to add carvedilol as a beta blocker. Very small dose you start with, and you can increase the dose up to 12.5. Add one spironolactone if the LV ejection fraction is less than 35%. This is very, very important point. Then add a dapagliflozin, that is SGLT2 inhibitors. We'll discuss in detail dapagliflozin shortly. Remember, whenever you're starting a diuretic, you have to understand that there are 3 important precautions that you should take. One is braking phenomenon of the diuretic. What happens? There is, if you are inhibiting one particular part, say suppose thick ascending limb of loop of Henle from the water reabsorption. So what happens is, other parts of the nephron is very intelligent. They will start reabsorbing more. So there is enhanced reabsorption from the other part of the nephron if one particular part of the nephron is inhibited. So whenever you are starting a loop diuretic, please add one spironolactone, that will be helping in preventing this braking phenomenon, it is called as. Next comes the diuretic resistance. Once you start the diuretic, what happens? It is especially seen in renal failure patients due to clogging of the uremic toxins on the basolateral membrane. Next we talk about the cardiorenal symptoms. So due to decreased intravascular volume, there is a pre-renal type of renal failure that may result in cardiorenal syndrome. Remember, there is a diuretic called as metolazone, extra point, where the star mark is indicating an extra point. You can mention in exam, but if you forget also, nobody will cut your marks. So it is metolazone. Metolazone is only thiazide diuretic, which is safe in renal failure, and it can be added to loop diuretics if there is a sufficient diuresis is not achieved. Let us now talk about ARNI drugs. The newer drug ARNI is an angiotensin receptor blocker. AR stands for angiotensin receptor blocker, that is valsartan, and neprilysin inhibitor. NI stands for neprilysin inhibitor, which is sacubitril. So neprilysin is an enzyme which degrades the substances like angiotensin 2, nitriuretic peptide, bradykinin, substance P, adrenomedullin. Remember, neprilysin is an inhibitor or enzyme which breaks down good molecules and we are giving a neprilysin inhibitor so that the atrial natriuretic peptide is not broken down and activity of ANP is prolonged. NT-proBNP, this is a test that is done, NT-proBNP. It is not a neprilysin substrate. Let us now talk about the third important drug. So first drug was beta blocker, first drug was diuretic, second drug was ARNI. Now third drug I am talking about is the beta blocker. Beta blocker in heart failure should be used in patients who are symptomatic or asymptomatic with 40% ejection fraction with LV remodeling. So this is the first drug which I am using in LV remodeling. What do you mean by LV remodeling? Remember our clinical case when I started my class. The apical impulse was displaced onto the left. The apical impulse, if it is displaced onto the left, it means that there is a hypertrophy, left ventricular hypertrophy or ventricular remodeling has occurred. Such patients should start beta blocker. Start with the lowest possible dose and achieve a sufficient euvolumia with diuretics before starting the beta blocker. Please remember, you should start with a diuretic. Once the volume reduction is achieved significantly, 3 days, 5 days, 7 days, then you start your beta blocker. There is a worsening of the fluid retention after 3 to 5 days if the beta blocker is started without achieving a euvolumia. What are the benefits of beta blocker? Short note question, very short note question in FMG or a NEET PG exam also this question comes. What are the benefits? Number 1, it controls the heart rate. Number 2, it reduces the blood pressure. These two are points which you need not have any logic because you know that beta blocker controls the heart rate. But most importantly, beta blocker maximizes the diastolic filling period. This is very, very important point. So it increases the diastolic filling time. It reduces the myocardial ischemia. It promotes regression of left ventricular hypertrophy. Beta blocker with left ventricular dysfunction, they reduce the mortality and hospitalization rates. Very, very important point. Patients with preserved systolic function, beta blocker therapy is used to improve the mortality and rehospitalization. Remember that hydralazine is a drug that is a calcium channel blocker along with nitrates if you use in combination for patients who are unable to tolerate the AC inhibitors. Next we talk about spironolactone plus dapagliflozin. Now this combination should be used in patients with persistent symptoms despite of you are using AC inhibitors, beta blockers, diuretics, all these you are using and patient is not getting any benefit. Now you start with dapagliflozin and spironolactone. Next comes one more drug called as ivabradine. Now this ivabradine drug is used in patients who have got heart rate more than 70, stable patients, and in whom beta blocker maximum dose is given. Even after that heart rate is not controlled, then you can start with ivabradine. So what is this ivabradine? Ivabradine is inhibitor of inward current, especially in the SA node. This results in reduction in the heart rate. So ivabradine reduces the hospital admission rate, ivabradine reduces the mortality rates. Ivabradine is very, very beneficial in patients with heart failure and especially who have got moderate to severe left ventricular systolic impairment, not diastolic, alright, systolic impairment. So there are clinical trials which are shown that patients who have got relatively higher heart rate, ivabradine is best suitable, especially who cannot use beta blockers, who have got contraindications for beta blockers. Such patients you can start ivabradine is a first line of agent. But it is ineffective in patients with atrial fibrillation. Sir, why? Because here SA node is firing at a very, very high rate. Hence ivabradine cannot be used. So in this figure, this will help us to understand the effect of treatment by doing comparison between the ventricular performance before the heart failure management started and after the management was started. So remember, on the y-axis we have got cardiac output. On the x-axis you are checking for the preload. So this is the normal graph. In case of, now this is the heart failure. Here the preload is very much increased, but the cardiac output is very much decreased. See, cardiac output is very much. So from point A to point B and point A to point C. Now this is what happens when you are using drugs like diuretics and venodilators, especially nitrates. So from diuretics and venodilators are bringing this heart failure patient to point A. Angiotensin converting enzyme and mixed vasodilators are bringing this heart failure to point B, whereas maximum benefit is achieved, that is point C, by using a positive inotropic agent like digoxin. Next comes the SGLT2 inhibitor, especially examples are canagliflozin, empagliflozin. These are anti-diabetic drugs which are used in heart failure, which are approved in the management of heart failure because it increases the diuresis, it increases the natriuresis, decreases afterload, decreases the effect on myocardial energetics, and decreases the preload. Hence, the left ventricular stress is reduced. Hence, the remodeling is reduced. So, what are the drugs which are having mortality benefits in heart failure? Very, very important point. Please mention in your exam. Beta blocker has got mortality benefit. ARNIs has got mortality benefit. Spironolactone, not all diuretics. Spironolactone has got mortality benefit. Hydralazine plus nitrate has got mortality benefit. Now, this is extra edge point for students, not for students who are writing their university exams, but for students who are going for NEET assessment or NEET exam. Now in this, remember, if beta blocker is given without achieving sufficient volume control, what happens? It may result in pulmonary edema. Now remember, you should start first diuretics, then check for the inferior vena cava diameter. Inferior vena cava diameter should be checked to assess U volume. Yeah. If the patient is in euvolumic status, then you start with beta blocker, and then diuretics can also be used to relieve the symptoms by decreasing the preload. If if this patient is still symptomatic, even after giving 4 drugs, then you should check the heart rate. If heart rate is more than 70, what is the drug of choice? Ivabradine. Ivabradine is an inhibitor of funny current or invert current in the SA node. But what is the limitation of ivabradine? You cannot use it in SA nodal disease. Any patient who has got 6 sinus syndrome, SA node disease, atrial fibrillation, atrial tachycardia, ivabradine will not act because SA node already dysfunction is there. Here the difference between ivabradine and beta blocker is both of them reduce heart rate, but beta blocker reduces heart rate along with blood pressure. Ivabradine reduces only the heart rate. That is very, very important. Next we talk about management of heart failure. Again, this is an extra point. We are aiming to block what? Sympathetic nervous system, renin, angiotensin, aldosterone axis, ADH activity, neprilysin, all these we are blocking. So sympathetic nervous system increases stress on the heart rate. Stress on the heart, it increases the heart rate, increases the chances of arrhythmias. Renin, angiotensin, aldosterone increases the salt and water retention, increases the edema and vasoconstriction. Natriuretic peptide may result in volume congestion. So all these are blocked by our pharmacological agents. Maximum mortality benefit in heart failure is achieved by blocking the sympathetic nervous system by cardioselective beta blocker. What are the examples of cardioselective beta blocker? Metoprolol, carvedilol, and bisoprolol. Now, landiolol is a new cardioselective beta blocker, which is mentioned in 2024, but still, it has to pass certain phase 4 trials. Renin, angiotensin, aldosterone blockade has to be done. If there is a heart failure, mortality benefit is better with AC inhibitors, AR blockers, because AC inhibitors increase the bradykinin level, and bradykinin is a vasodilator. Now, coming back to the topic now. For all my students, I request you to please mention about refractory heart failure management. For refractory heart failure, how do you define? Patient has got less ejection fraction, patient is symptomatic, even after using ARNI beta blockers, diuretics, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. This is the definition of refractory heart failure. So management depends on QRS on ECG. Take an ECG. If it's showing wide QRS LVBP, then you should go for cardiac resynchronization therapy. What is resynchronization therapy? We'll discuss. If the QRS is normal, then you should go for implantable cardiac defibrillator, ICD, or LV assist device should be used, or patient is an ideal case for cardiac transplantation. Alright, so before understanding all those parameters, now let us see how to manage pulmonary edema. Now, pulmonary edema can occur in any form of heart failure. Patient usually presents with fine basal crepitations. Last point you can see here, fine basal crepitations with high blood pressure. Now, how do you diagnose this condition? 60-year-old smoker, hypertensive with prior history of myocardial infarction has presented to you with breathlessness, cough, and frothy sputum, hemoptysis, orthopnea, paroxysmal nocturnal dyspnea, and swelling of the legs. In this patient, the X-ray chest is showing bat wing appearance and cardiogenic form of pulmonary edema. Identify the clinical condition. What is the diagnosis here? It is acute decompensated heart failure with pulmonary edema. Now, in this patient has already a known case of reduced ejection fraction, And these are the symptoms which are showing decompensation. Hence, we are calling it as ADHF with pulmonary edema. What is the etiology of pulmonary edema? Cardiogenic etiology unless proven otherwise. Few cases, renal etiology is also seen. In case of X-ray findings or LA pressure if you see, left atrial pressure if you see, and radiological findings if you compare, left atrial pressure between 12 to 19 millimeters. So normally left atrial pressure should be less than 5 to 10. If it is 12 to 19, it is increased. Cephalization of the pulmonary vein is seen. 19 to 25 indicates curly B lines. I will show you an X-ray showing curly B lines. What are the curly B lines? This is because of dilated interlobular septa. Next, more than 25, you see pulmonary edema. Curly C lines, curly B you have seen, is it not? Curly C is reticular opacities at the base of the lung. They have no significance. Curly A lines means dilated anastomotic channels between the central and peripheral lymphatics. If you are a final year student and you are given an X-ray of chest with pulmonary edema or bilateral cardiomegaly, they'll ask you curly A lines, curly B lines and curly C lines. So you have to be prepared. A is peripheral lymphatics. C is reticular opacities at the base. B is very important for our pulmonary edema diagnosis. It is dilatation of the interlobular septa. Interlobular का मतलब है दो lobes के बीच में वाला septa. Alright, in between the two lobes. For example, here you have got two lobes. So here you have got a line here, interlobular septa. This arrow mark. This is the curly B line. How do you manage pulmonary edema? Patient has to sit up. Patient has to given high flow oxygen, nasal oxygen or oxygen has to be given. CPAP should be started 5 to 10 millimeters of mercury. Tight fitting mask. What are the drugs that you need to give to the patient? Glyceryl trinitrate has to be given. Buccal glyceryl trinitrate has to be given oral or buccal sublingual. Then administer furosemide because this combats the fluid overload. Please remember this 5 points you have to write in exam in the management of pulmonary edema. Pulmonary edema is a short note question for you, if not a long question. Pulmonary edema management you need not write in your essay question for heart failure. Now how do you manage? I already told you, high nasal flow oxygen, then Lasix has to be started, then nitroglycerin infusion has to be given, morphine can be given because it pushes the blood from intravascular to extravascular compartment. But the best management is urgent hemodialysis to achieve euvolemia. Now in this patient we have got septal lines or curly B lines. This is enlarged cardiothoracic ratio, cardiac silhouette because of coexistent heart failure. Now these are the dilated hilar blood vessels. Dilated hilar blood vessels. What are the non-pharmacological management of heart failure? Non-pharmacological management of heart failure is resynchronization therapy. One by one we will see. Implantable cardiac defibrillator ICD and pacemaker. So here if you see implantable cardiac defibrillator, these are the device in which the patient presents to you with symptomatic ventricular arrhythmias, ventricular tachycardia and heart failure. And here there is a very good prognosis if you are timely if it is used. Next is resynchronization devices are indicated in patients who have got intraventricular conduction delay. So we call it IVCD, intraventricular conduction delay associated with severe symptomatic heart failure. Here both LV and RV are paced, both right ventricle and left ventricle are paced simultaneously to generate a more coordinated right and left ventricular systolic contractions. Alright. So this is what is a resynchronization that we are doing. In this chest X-ray, if you see there is a biventricular pacemaker that is implanted. See, this is the pacemaker here. Alright. So we have got a biventricular pacemaker and a defibrillator. This is the defibrillator here, and the pacemaker probes are coming up to the ventricle here, interventricular septum here. So this is one pace lead, and this is another one which is coming into the atrium. So we have got right ventricular in position in the ventricular apex, and it is used for pacing and also defibrillation. Whereas this right atrial lead, so this is the right atrial lead. This is helping in pacing the right atrial appendage. So coronary revascularization or CABG can also be used, especially in patients who have got sometimes hibernating myocardium, small amount of endomyocardium. Inside the myocardium, what happens, small amount ischemia is there which is chronically causing heart failure. Such you have to identify by doing certain tests, that is nuclear cardiac imaging, and then such patients will have to take for CABG or PCI stent implants. But the ultimate treatment here is cardiac transplantation. Cardiac transplantation is one of the most successful treatments in the patient with intractable, untreatable heart failure. You have to write in exam. Most common indication of cardiac transplantation is coronary artery disease followed by dilated cardiomyopathy. Here, this is done when all different modalities have failed, especially in young patients. So what are the contraindications? Remember, number one, pulmonary vascular disease, if it is present, then it's a contraindication. Complex congenital heart diseases like Eisenmenger syndrome, primary pulmonary hypertension is present. That is also an important absolute contraindication for heart transplant. Heart-lung transplantation can be done successfully in Eisenmenger syndromes, and the lung transplantation for primary pulmonary hypertension patients. What are the important complications of cardiac transplant? Important complications are rejection, number one. So there might be very, very high chance of rejection. You have to start with high doses of glucocorticoids or immunomodulators, azathioprine, cyclosporin, to avoid this. But even then also, rejection has been reported. Apart from this, accelerated atherosclerosis. See, previously the heart was having atherosclerosis. You have changed the heart but not the habits of the patient. So this atherosclerosis which was there in the old heart, it will also come in the donor heart, and this may result in chronic, probably because of coronary artery disease or as a manifestation of chronic rejection. Also atherosclerosis can come. Next comes the infection, cytomegalovirus and aspergillus opportunistic infection. These are the major causes of death. So which infection causes death in cardiac transplant cases? Cytomegalovirus or aspergillus, a fungus or viral infection. Talking about the ventricular assist device. So in the left ventricle, if you put one device, it may assist the left ventricle to contract, something like that. Alright, so especially in patients who have got reversible forms of heart failure like viral myocarditis, especially in patients who are waiting for cardiac transplant, in such patients you can use ventricular assisted device. What are the complications of heart failure? And this you have to mention in your exam, university exam going students. Everybody, you have to write complications even if they don't ask. For a long question, essay question, they're asking a disease, you have to write its complication and sometimes management of complication also. One single line you can write. So heart failure can result in renal failure, hypokalemia, electrolyte disturbances like hypokalemia, hyperkalemia, life-threatening hyperkalemia is seen. Hyponatremia is very, very common. Impaired liver function. So liver function is impaired, kidney function is impaired. Thromboembolism because of accelerated atherosclerosis. Then arrhythmias are also very, very common, especially atrial fibrillation, ventricular tachycardias are common. And sudden death is also an important complication of heart failure. Hope you have understood the lecture. And in our next lecture, we will be talking about other topics of cardiology. Thank you.